Hey everybody, welcome back. This is going to be I think it's lecture 5. That's the second lecture in our pathophysiology lecture. And we left off here. Yesterday we were talking about acid base, and so I gave an in-class type review of acid base, but I want to cover it again just so that you'll kind of have something to go by to study. I'm not going to get too crazy into this. The exam that we're going to take is not full of acid-base questions. There are a couple. But we will expand on this when we get to respiratory, and we'll expand on this when we get into other chapters. So, I don't want it to make it look like this whole exam is going to be on this. It's not, but it's super important that you understand it. You have to understand the basics of it now. And as we move through class, we will expand on it. National Registry for the AEMT exam has a lot of acid-based questions on there. So, irregardless, it's super important that you understand it. Hope everybody's doing well. Hope everybody's staying warm. You're not getting beat to death too bad out there in the field. And so we'll get started. Get myself out of the picture. And so this is where we left off. I kind of want to go to this slide, though, and come back to this one. All right. And so here we are. Let me get a pen out. All right. So here we are. And so we were taught in EMT school. You were taught in EMT school that here we have first of all, we have pulmonary circulation right here on top. And we have systemic circulation on the bottom. Now, pulmonary circulation just means that blood is receiving oxygen and getting rid of CO2 up here. Comes back over here to the left atrium through the bicuspid valve to the left ventricle, up through the aortic valve, up through the aorta, makes that big curve there, falls down. And so when we get down here to systemic circulation, this is where you're having the exchange of O2 to the cell and CO2 going back into the red blood cell. And so when we talk about a couple things, one, we talk about plasma, right? And so you have roughly around 45% of your blood volume is plasma. 55% of that is cellular blood. These guys right here, the cells, right? And then 5% of other things. Anyway, and so we know that we talked about the red blood cell, the RBC. All right, and so the RBC's job is to deliver O2, right? But it does that with hemoglobin. And the cool thing about hemoglobin is that after it drops off that O2, it's going to pick up the CO2 and deliver it back up here to the alveoli. And you can see that once it gets up here, that hemoglobin releases CO2, and then we simply breathe out CO2. All right. Plasma is mostly water. All right. What we didn't really expand in EMT school, and maybe you did. I know if you had Instructor Riggs, I know she probably gets into this. I don't get into it too much because, I do sometimes, but it's more of an AEMT type thing, is acid base. And so we know that roughly 23%, I guess, is what it says up here, comes back up, of CO2 comes up here but 70% of this O2 is going to be cleaned a different way, right? And that's through the buffer system, right? So you got to have a buffer system. And with the buffer system, there's a little bit of chemistry involved. And so just like I said before, plasma is mostly water. So let's say H2O. That represents water. We're talking about CO2. That's what we're talking about, the waste, right? And so if we add these up, we'll get something. We'll get H2CO3, right? H2CO3 because two hydrogens. There's one oxygen there. There's two oxygens here. So that gives me three oxygens. There's one carbon. So H2CO3. Well, H2CO3 is an acid. It is a weak acid. And so that's what we're talking about, this weak acid, and how it's going to play a role in acid base. And so what ends up happening is you have H2CO3, and what it can do after it's collected here, it can disassociate to where we have H plus, whoops, let me get an eraser. Hold on. Strut remorse is already messing up. Already messing up. We get H, so there's one H, HCO3. And this is known as bicarb. And what bicarb does is it reduces acid. It reduces acid. And so this is how your body manages its acid-base system. All right. That's how the body manages this acid-base system. Now let me go back to this slide over here. So you have CO2 plus H2O yields H2CO3, which is carbonic acid. The body has to get rid of CO2. It does this in two ways: the red blood cell and the hemoglobin. That RBC is filled with carbon dioxide. It reacts with water, forming H2CO3. I said it's a weak acid, and it's called carbonic acid. So we have to control this carbonic acid or it'll kill the cell. And so just like I showed you before, this H2CO3 dissociates into HCO3 plus a hydrogen there. But the HCO3 right there is known as bicarb or bicarbonate. And you can associate bicarbonate with baking soda that reduces the pH, the potential for acid, making it more acidic or more basic. It just depends, right? And so let me see if I can put this back out here. CO2 plus H2O yields H2CO3, which yields CO3 plus hydrogen. Now, what this is saying is this, and you have to think about what's the number one job, and I've said it 100 times, but the number one job of pre-hospital care providers is to stop cellular death. And what they're trying to get through everybody's head here is that if you're not breathing appropriately, right, or you have some type of medical issue like diabetic ketoacidosis, something like that, then you are going to develop acid and you're going to kill the cell. And that's really, at the end of the day, what they want you to understand. So if you have an increase in CO2, right, then what you're going to develop is an increase of this hydrogen ion. And roughly it's like a 20-to-1 ratio. You have 20 bicarbs to 1 hydrogen. And what ends up happening is the more hydrogen that develops here, I better put a plus on that, make my chemistry professor happy. The more hydrogen that you develop here, the more acid you're gonna collect, and it'll eventually overcome the amount of bicarb that you have here. And so what you have to understand in this is there's 3 ways that we can reduce this acidic content. One, the quickest way is the body's natural way of doing this is the buffer system, right? So what is happening in this case here is this, we're trying to shift this reaction back to the left to reduce the amount of hydrogen ions that we have. And so the best way, again, the quickest way is through the blood, the body's natural way of handling this. Well, if the natural way is being overcome, the second way, the fastest way will happen within a couple of minutes, is to open this patient's airway and ventilate them and allow them to blow off more CO2. Because if we can reduce the amount of CO2, then we will reduce the amount of hydrogen ions and we will increase the amount of bicarb. The third way to do this, that's usually not an option for us, is through the kidneys. The kidneys can pee off the hydrogen ion and it can recollect the bicarbonate. Can recollect that and then redistribute the bicarb throughout the body. Right? So those are the 3 ways that we have open to us. Now, what you need to understand is when you come across somebody who's acidotic, what is the body going to do to help blow off the CO2? And so we can go back a slide and remember what the chemoreceptors do. Remember, you have your central chemoreceptors and your peripheral chemoreceptors. And if we look at the central chemoreceptors, we will see that, wait a minute here, the central chemoreceptors monitor that hydrogen ion, right? They also monitor CO2. And so the central chemoreceptors is going to say, wait a minute, we have too much CO2 and we're collecting too many hydrogen ions, which equates to acid. And it's going to send a message, right? It's going to send a message right over here. And it's going to affect the diaphragm. It's going to tell that diaphragm, hey, you need to contract deeper and harder, and we need to increase the respiratory rate from 12 to 24 to 30. We need to blow off this CO2 in order to reduce the amount of acid. And when we talk about that, when the body's attempting to reduce CO2, We generally associate that with respiratory acidosis. Oops, that was nice. Respiratory acidosis. Right, because that's what we're dealing with. Now, when we have that chemical equation up again, and let's say we have H2CO3, and we're going to end up having our CO3, HCO3, right? Plus hydrogen. This is bicarb. And when we're dealing with a situation where our bicarb is dropping, right? It's been eaten up by these hydrogen, by all the acid. All the acid is taking away the bicarb. The body's becoming really acidic. That generally, we term that as metabolic acidosis. Right? Because that's, respiratory acidosis comes along, and sometimes, like in an asthma patient, they'll have just respiratory acidosis, right? They won't generally, they don't all turn into metabolic acidosis. But if you had like a diabetic patient who is, just throwing ketones out there like crazy, and they're really acidotic from that, then the body will still attempt to blow it off, but it will also start, all these hydrogen ions will start affecting that level of bicarb. And when it starts affecting the level of the bicarb in the body, we generally term that metabolic acidosis. All right. Good deal. So that's basically what you need to know about that. Again, I'll just cover these slides real quick. HCO3 inside blood plasma is redistributed back into the RBC. Inside the red blood cell, we dissociate for the last time between H2O and CO2. We'll keep the water, send it through, and send the carbon dioxide through the pulmonary capillaries and out the lungs through expiration. So that's generally how it works. We try to get those red blood cells up there. They will get rid of that CO2 through the alveoli, and the other part is what I just taught you, and that will continue its track. And it's in a normal patient, it's constantly changing from acidic to non-acidic, back and forth. It only becomes a problem if we have somebody cardiac arrest, severe asthma, any type of diabetic ketoacidosis, things like that. All right, the respiratory center. We talked about that earlier a little bit. The size of the thorax is essential for breathing. Size is controlled by breathing muscles, right? And so muscles, work to contract the diaphragm and and also to pull the rib cage down and out to allow for breathing. Let's talk about the Pontine Respiratory Center, aka the pneumotaxic center. There you have your pons and your medulla, right, located in your brain stem. These are responsible for controlling respiratory drive. That's why it's so devastating to have a brainstem injury. VQ ratio, ventilation versus perfusion. It's not, well, I don't think it's hard. It can be made hard, and if you don't look at generally what they're trying to tell you here. What they're generally trying to tell you is there's two ways to die. You can bleed to death, right? Or you can die of hypoxia, but either way you're dying of hypoxia, right? Because if you're bleeding out and all of your red blood cells are dropping on the floor, then they can't make it back to the cells to drop off oxygen, right? So you're going to die of hypoxia either way. So if I have an upper airway occlusion, I'm going to die of hypoxia. If I am bleeding out from a gunshot wound, I'm still going to die of hypoxia. And that's what the relationship is trying to kind of get through to you on that. So V is for ventilation. Q is for blood. So V would be like a pulmonary embolus, right? Q would be a gunshot wound. So that's what they're trying to get through to you. O2 is present for gas exchange and blood supply is not adequate. So we have O2 that said, we're able to breathe. We're able to breathe and get oxygen in. It's collected in the alveoli, but a red blood cell doesn't come by to collect that oxygen to distribute it throughout to the cells. And that's what it's talking about. Any disturbance that prevents the lower airways from being oxygenated, preventing gas exchange. That's going to be the V. So determine ventilatory or perfusion problems, and attempt to correct it. So if it's someone who is in respiratory failure, please bag them. That will correct the V. If someone is bleeding from a gunshot wound, please apply direct pressure. That will correct the Q. But it's our job to determine within the first couple of minutes through that primary assessment of what we need to correct in order to correct this VQ relationship. Perfusion disturbances. So hypoxia is the deficiency of O2 at the tissue level. Hypoxia secondary to perfusion. There's not enough blood to pick up the oxygen available in the alveoli. Okay. So treatment using O2 will help. However, until that blood is replaced, so gas exchange can take place, patients will not get any better. And so we're going to get into pharmacology, and we're going to get into IVs, and we're going to talk about we can start 4 large bore IVs, and we can start dropping normal saline or lactated ringers or whatever fluid you want to choose from. And we can arrive with a blood pressure. That we can bring somebody's blood pressure up from 40 palp up to 90 palp. The problem here is that they're going to die in a couple of days because their kidneys are going to die because they didn't get fed oxygen. And once that organ system dies, the next organ system will die, and then the next until the patient's dead. So what we need to do in these situations is recognize that we have a perfusion problem that's a Q problem. And we don't need to start our IVs while we're sitting on scene. We don't. We need to get going. We need to get that patient to a trauma center as fast as possible in order to receive that life-threatening, life-saving surgery so that patient can survive. There's nothing that will save that patient until we get blood in the field, and which, we know a couple of services around this area are providing that. It's amazing. I work a part-time job in the emergency department, and I've seen patients knocking on death's door, and it's amazing just after 100 milliliters of blood has been administered that their color starts coming back. They start getting that energy back. They just turn the corner, and it's so rewarding to see that. I'll be glad in 2025 when we can get everyone on board. And really, we've been fighting for this for years and years and years to get blood in the field. I think it's finally happening. Should have happened in 1970. But anyway, get off my soapbox. Oxygen transport, red blood cells, right? We talked about this quite a bit. Some facts about the red blood cells. They generate their own energy through anaerobic metabolism. It's the only cell you'll see do that. Aerobic metabolism is what most cells need. But isn't that nice? Because they don't use any of the oxygen that they're providing to the cell. They don't need it. So they don't take any. And that's nice. They're a large surface area for the diffusion of gas molecules. Because remember, right, inside that red blood cell is hemoglobin carrying O2. So we need it large so that it can diffuse really good. And then we need to pick up that CO2. Don't forget the waste. All right. And it contains hemoglobin. So let's talk about hemoglobin. Oxygen carrying protein. The hemoglobin comes from a pigment called heme that gives whole blood its red color. If iron is attached to hemoglobin molecule, this allows 4 molecules of oxygen to be attached. So occasionally we'll see someone who we call anemic, and meaning they have low blood cells. And a lot of times they're low on hemoglobin, or they're not really low on hemoglobin. I'm sorry, they have hemoglobin, but they don't have, their iron is low. And if your iron is low, it doesn't hold all of those oxygen molecules into that hemoglobin. Again, you can think of iron as the seat belt. Iron is the seat belt for the oxygen molecule that rides in the hemoglobin. So it transports CO2, waste products of metabolism. So we know that. That's why that CO2 is brought into that red blood cell. It attaches to that hemoglobin. And that's also, if you think about it, hemoglobin, it likes CO2, but it loves it some CO, carbon monoxide. Carbon monoxide is hemoglobin's first love. They broke up. It was a bad breakup, but hemoglobin still loves carbon monoxide. And when carbon monoxide comes around, hemoglobin will leave CO2 in the wind just to be able to go out with carbon monoxide. As blood flows through the lungs, CO2 is released from the hemoglobin as it's exhaled. And we know that it releases that CO2 into the alveoli. And 98.5% of inhaled O2 is bound to hemoglobin, which makes sense because oxygen doesn't like water, right? We know this when we go swimming and we put our head underwater, we can't seem to breathe. Well, same thing here is oxygen does not like to ride around in plasma. It doesn't mix because plasma is mostly water. So we talked about oxygen transport being transported 2 different ways. There's a very small amount that is dissolved in the plasma, 1.5%, but 98.5% rides along in hemoglobin. Deoxyhemoglobin means there's no oxygen attached to the hemoglobin. And we'll see that in carbon monoxide poisoning. Carbon dioxide is a waste material. It's dissolved, like we said, in the plasma. It also attaches to the hemoglobin. And we talked about how important bicarbonate is in that process. Well, yep. Let's keep going here. Gas exchange, O2 and CO2 move through the cell through the process called diffusion. O2 moves into the blood cells because there's little present. CO2 moves out of the cell for the same reason. And I compare that to like those little Gatorade packs you could drop in water. You know, if you have a bottle of water, you drop the little Gatorade pack in, and you can see those particles start diffusing throughout there. And they're doing that because at the bottom of that water bottle, there's not a lot of them there. So that's where they want to go. That's where they want to go. Blood. Blood functions, the function of blood, transportation, regulation, and protection. It maintains a fluid balance in blood. We have clotting that happens here as well through platelets, but also there's albumin, fibrogen, and all those other things that ride around in plasma to help blood clotting. The venous system. So, you know, we talk about how blood comes out of the aorta. Wow. Nice. Let me find where I was at. There we are. We talked about how oxygenated blood comes out of the aorta here, right? Comes around the aortic curve, comes down the aortic artery, right? As these arteries become smaller, they're called arterioles. Right? And then they branch off and become venules. And the larger they get, they become veins. And what we're talking about is the venous system. We're talking about veins. The function of that venous system is supplying the right side of the heart with blood. Deoxygenated blood, but blood not itself. Somebody has to pick up the garbage, and the right side of the heart is proud to do that. If volume decreases, the amount ejected from that left ventricle to the arteries and then to the cells is also decreased. So if we are bleeding out down here somewhere, then we're losing volume coming back up here, right? We're going to end up losing volume there. Its major role here is maintaining blood pressure through adequate perfusions to the cells, right? So your venous side is, these are the guys who are going to vasoconstrict. They have, what's the word? Valves. They have valves that help return the blood up here to the heart. Valves are like, you'll have a vein here, and that vein will kind of have this like that. It's called a valve. It reduces the size of the vein to increase the pressure to allow blood to travel uphill. So several parts of your veins have these valves. Hydrostatic pressure. So when we talk about hydrostatic pressure, what we're talking about is the force inside the vessel or the capillary bed. It's generated by a couple of things. It's generated by the contraction of the heart and the blood pressure. It's that push inside the vessel or capillary and into the interstitial space, right? So it's pushing, because the pressure is so high and the contraction of the heart is so great, this like water hammer. All right, let me go back up here real quick. I can show you what I'm talking about. Let's erase this. Man, hard to erase. But it's getting it. All right. All right. So let's say, for instance, your patient, let's make them a congestive heart failure patient. Okay. And congestive heart failure patients tend to have a blood pressure of around 180 over 110. That's not too shocking for someone with congestive heart failure. And that is because, for whatever reasons here, we're preloading because afterload is so high. Afterload's the next slide after this. All right, afterload is so high. And this left ventricle right here is having to pump against that afterload. So it's stretching out. Because the pressure in the system, it doesn't really matter what number you give it, but we'll give it we'll say 120. The pressure inside this closed container works really good at 120, right? Well, in this case, the pressure in this container is 180. And look what you're having to pump against. Remember, I'm having to take blood and pump it uphill. I have to go uphill and around this aortic curve just on a good day, right? To get blood out at 120 psi on a good day. I have to pump uphill and this curve right here, you have to get blood up and around a curve. Well, in this case, we're pumping against a pressure is really high. It's 180. This left ventricle is preloaded out. It's throwing blood out. And so the velocity of this blood is super high. And it comes around. And what happens when it gets to the curve? It drops. It drops. And the velocity, it's extremely high. And it's causing that speed of blood to come down. We just talked about how arteries become smaller. And these arteries start getting smaller, especially down here at the capillaries. And they become arterioles. Right? So they become super small. And we're talking about the plasma part, because plasma is mostly water. Cellular blood is not going to get through here. You're not going to lose RBCs. You're not going to lose white blood cells. You're not going to lose platelets. But what you are going to lose is the water part of the plasma. And it's going to hit this right here. Guess what? It's coming out. It's going to rush out because it can't. It's entering those arterioles so fast that it's coming out. And when it comes out as edema. And this is why you have patients with congestive heart failure who have lower extremity edema. That's because of that. I hope that makes sense. Right? So let's go back to where we were at. So that is hydrostatic pressure. And because it's pushing that, it's the push inside the vessel or capillaries into the interstitial space. That interstitial space is just what I was showing. When that blood comes out, it goes to the interstitial space. And so hydrostatic pressure promotes edema, swelling, excessive fluid outside the vessel. And so you can associate hydrostatic pressure with an increased blood pressure. So left ventricle failure. So again, we go back to this. And what I showed you earlier was that congestive heart failure patient. And I talked about, man, I wish it would stop doing that. And I talked to you about, let me get back over here to this, how they're preloaded out, that myocardium has stretched out. Well, think about it. If I'm living, I don't know I have high blood pressure. And so I'm walking around right now with a blood pressure of, let's say, 170 over 98, something like that. And so we just talked about how that affects things. Well, this left ventricle has been going to the gym, and it's been gaining muscle. It's swole up, right? But this fibrous tissue is like a rubber band, and it starts losing its stretch. It starts not being able to eject all that blood that it needs into that aorta. And when that happens, that blood is going to back up into those pulmonary veins, right? And then from the pulmonary veins back into the lungs. So increased hydrostatic pressure forcing the fluid outside of the vessels already happening. And this heart is just losing its punch. And that's left ventricle failure. With that, remember I said this a second ago, said that here's your alveoli. That fluid is going to start backing up, coming out of the pulmonary vein. Oh. Coming out of the pulmonary vein, that fluid's going to start backing up, and it's going to start smothering these alveoli. So guess what can't happen? A gas exchange. And this is all because of left ventricle failure. Otherwise, these alveoli would be fine. There would be no problem. They would still collect O2 with no problem. But now they can't have a gas exchange. So now we're dealing with somebody who's hypoxic with the left ventricle failure. So, plasmic oncotic pressure to save the day. So, let's say we get out there and we call for ALS for a paramedic unit, and we take him to the hospital. We give him a bunch of nitrates, and we're able to reduce that blood pressure. And what that does is it reduces afterload. Once we do this, it reduces all of that. But once things go back to normal, a pressure gradient will be established. And that pressure gradient, through the help of albumin, will start attracting that edema back into the vascular system where it belongs. The swelling starts going away. Things start returning back to good. So this would be the opposite of hydrostatic pressure. All right, so pump function of the myocardium, cardiac output. So let's get these definitions down. Cardiac output is the amount of blood ejected from the left ventricle in 1 minute. If we look at cardiac output, we can have heart rate multiplied by stroke volume. And that is equivalent to blood pressure. There's major influences on blood pressure. Normal cardiac output for adults at rest is about 5 liters per minute. The left ventricle pumps the entire blood volume through the vascular system in 1 minute. Heart rate, number of contractions in 1 minute. So increase and decrease of heart rate, primarily factors, the parasympathetic and the sympathetic. We have neural stimulation, so epi and norepi. Beta 1 increases in heart rate and contraction, right? So remember, beta 1, 1 heart, beta 2, 2 lungs. Stroke volume, all right, so we're going to talk about stroke volume. It's the volume of blood ejected from the left ventricle with each contraction. And that's determined by preload, myocardial contraction, and afterload. So if we look at cardiac output here for a second, we can say that blood pressure is affected by this. So cardiac output equals heart rate times stroke volume. So if I need to affect blood pressure, I need to affect one of these, right? So if I want to increase cardiac output, then I will actually be increasing blood pressure. And so heart rate, if I can get the heart rate higher, then essentially I will get the blood pressure up. And so we know that epi is able to do that, right? Because we just said that epi is part of that sympathetic part of your nervous system. It's released when you're in shock, when your blood pressure is low. And we know epi has a property of beta 1 and beta 2, but the beta 1 is going to increase the heart rate. Let's go back. So now let's look at stroke volume. So stroke volume comprises of preload, myocardial contractility, and afterload. So if we can affect one of these three, then we can affect blood pressure. Let's talk about preload. So preload, diastole, the phase of the heartbeat when the heart muscle relaxes and allows the chamber to fill with blood. And systole is the phase of the heartbeat when the heart muscle contracts and pumps blood from the chamber into the arteries. Remember, you have a patient out in the field and you put them on the monitor and you get that, and we call that asystole. A means without contraction. So preload is the degree of stretch on that left ventricle before it contracts. The greater preload prior to contraction increases the force of contraction, right? So we just talked about how that left ventricle earlier was preloaded out, right? Right, so that left ventricle right here is that it's a muscle and it can stretch. It's stretching to increase the amount of contractility, because if I can push blood harder, right? If I can increase that strength of contraction, then realistically I can send more blood out. I can put more blood out. the problem here, well, that's the next slide. Let me go to the next slide. The two key factors here, though, is venous return, the volume of blood returning from the body to the right atrium, and the duration of ventricular diastole. So I can only go so high with that pulse rate. Once I get to 160 beats per minute, I lose that filling time. Right. And then also, if I'm bleeding out, then I'm losing volume coming back to the right side of the heart. If I'm losing volume, that's less volume to circulate, and it's less volume to collect inside that left ventricle to help it stretch. So these are temporary. It's part of compensation. It means I can only compensate for so long before, I can't compensate any longer. In diastolic, the duration of the ventricle diastole will reference to the heart rate, and we just kind of talked about that. Too fast, it won't fill. We talked about this too, venous return. So the greater the preload, that will increase the stroke volume, which will increase cardiac output, which will increase blood pressure. And that's just what we talked about a second ago. Cardiac output is equal to heart rate multiplied by stroke volume. Inside stroke volume, we said preload is one of them, right? And so that's what that means. If we can increase heart rate, we will increase cardiac output. If you can increase stroke volume, you will increase cardiac output. Right, and so contractility, well, epi's going to help us with that. Beta 1 is also going to increase the heart rate, and it's going to increase contractility. The problem here is, as we go to compensate, we're compensating, which leads to decompensating. Anaerobic metabolism. That will start messing up everything. That will start decreasing the strength of the contraction. And then we've had a bad day. Afterload, right? So we have preload and afterload. So afterload is the resistance the left ventricle must overcome to circulate blood. And so afterload is just that. So again, if this is set up to pump at 120 psi, and the system is charged at 180 psi, that left ventricle has to overcome that pressure. And afterload, if it's increased, then you're going to have an increase in hydrostatic pressure. Systemic vascular resistance. So this is what epi is going to do for you. It's going to take those vessels and vasoconstrict them. It's going to cause that blood to move to the core of the body. And this is why in shock, when the blood is moving around, your extremities are cool. Right? Because blood is being moved, and blood, one of the properties of blood is being warm. Right? And so your extremities are cool, that blood's moving around. And so we're going to see this with what part of the blood pressure, right? And so if you think about systolic blood pressure, that's telling you the overall health of the left ventricle. Diastolic blood pressure is talking about the size and the diameter of the vessel. So if epi's been released and your patient is vasoconstricting, we'll see this with trending blood pressures. But we'll notice it in the diastolic, right? 120/80, 119/88, 119/94. See, all those diastolics are trending. They're telling you a story. They're telling you that your patient's vasoconstricting. Right now, the overall health of the left ventricle is good, but the vasoconstriction is happening. As the left ventricle preloads out, as epi's released, as pulse rate goes up, the overall health of the left ventricle will soon start to be affected. And that's when you're going to start seeing 100/80. Sometimes you won't even be able to get a pulse. And we'll call it 90 palp, or 84/70. See how close these are in range? We have the autonomic nervous system, right? And so direct neural stimulation from the sympathetic nervous system causes the vessels to constrict, increasing resistance and pressure. And parasympathetic nervous system causes dilation, reducing resistance. And we talked about that slide. So what I mentioned earlier about narrowing pulse pressures is defined as 25% of the systolic blood pressure reading. So here we have 132/74. If I take 132 minus 74, I get 58. If I take 25% of 132, that's going to give me 33. 58 is greater than 33, so this blood pressure will not be narrow. If we start noticing narrowing pulse pressures, we know we have a problem. And that's something we need to be on the lookout for. We talk about microcirculation, the flow of blood through the smallest blood vessels. But this is where a lot of your oxygen exchange takes place, at these capillaries. These precapillary sphincters control the movement of blood through the true capillaries. Cold temperatures can shunt blood away from these areas too, as well, just like shock can. Baroreceptors, these are important. Baroreceptors monitor the stretch of the aortic arch and carotid sinuses. And what they're looking for is, that's what's going to tell the cardiac center in the brain, hey, we got a problem, release epi, norepi. Because if they don't feel the same amount of stretch, they don't feel the same amount of blood inside, then they're going to send messages to increase the blood pressure. right? Impulses to increase impulses to the medulla, parasympathetic, normal. And so I'm trying to remember this slide. It's been so long since I taught this slide. Hang on one second. So if you have increased blood pressure, you have impulses to increase to the medulla, you have an increased baroreceptor stretch, increases blood pressure. What ideally we want to do here when the parasympathetic nervous system takes over is it will decrease the constriction and return heart rate to normal. I think that's what the slide's supposed to be showing. And our last slide here, the vasomotor response to blood pressure. We're trying to use the muscles and along with the vessels to constrict blood from these legs and send blood up to the core of the body to increase blood pressure. All right. I think I kept it close to an hour long. This is going to be our final PowerPoint presentation for anatomy and physiology. Good luck on the exam, and I will see you guys in class.